Test, test, test. Okay.
And how do I advance this?
Oh, do you have your mic on?
No, I'm going to use this.
Oh, you are? Okay.
Yep, it works. Good evening. Welcome to UCLA. Thank you all for coming. I'm Tony Schiff. I'm going to moderate the program tonight. I'm a lawyer, a healthcare lawyer here in Los Angeles, and I'm a adjunct professor in the Department of Health Policy and Management here at UCLA. We have a great program for you tonight. Is merger mania healthy? And that's the keynote question. I want to give a little bit of credit to all people. You will not probably have seen this editorial because most of you don't get a newspaper, and you should. Actually, my mother, who'll be 95 on Friday, does get a newspaper, and she sent me this. So I'm duty-bound to give the LA Times credit for writing an excellent editorial on this subject. And if you haven't read it, the July 9 edition of the Times, this is an editorial that's quite well worth reading. Well, merger mania is a fact, and we have lots of evidence of it. It's not just with the payers, it's not just with hospitals, it's throughout healthcare. I believe that the Wall Street Journal reported yesterday that Walgreens and Rite Aid are now talking about merging as well. So indeed, we have mergers occurring across the spectrum of healthcare. And a number of parties, a number of publications have written about it, and quite impressively, the Atlantic's article, Anna Wild Matthews' article, Healthcare Providers Insurance Supersize, which was followed up recently on October 19 with another article from Anna about the cost of care going up in hospital systems that have been hiring doctors. And then we take a look at the payer community. Obviously, Anthem has proposed to get together with Cigna. Aetna is wanting to acquire Humana. These numbers here are pre-merger. Centene and HealthNet have gotten together. So in fact, we're seeing tremendous consolidation at every turn. And what we're left with then is, assuming that the Federal Trade Commission and the Department of Justice approve these mergers, we're left with really three major insurance companies providing the bulk of the private insurance in the United States. It's really quite something. In fact, payers have been consolidating for a long time. I wrote an article 6 years ago, a peer-reviewed article entitled Physician Collective Bargaining, and the data that I looked at that point indicated that in the 1,800 largest markets in the United States, and if you think about 1,800 largest cities, we're really getting down there when we say 1,800. In fact, most of the markets, 70% of the market was really impacted by three payers. And so this is well before the mergers that we're discussing tonight. And indeed, the payers have their own specifications and discussions as to why they believe that this is appropriate. They note that they're reacting to the consolidation that they're seeing from the provider community. That in fact, they believe that they need to get larger in order to have negotiating strength with those providers. In addition, they believe that they can gain specialty expertise in areas involving government contracts, Medicare Advantage, as well as a number of the Medicaid contracts, which has been a big vehicle of expansion under the Affordable Care Act. They also note that they have economies of scale when they combine. And indeed, they have points in that regard. Health systems have also gotten together And in fact, last year, there were 95 mergers of hospitals in this country. The number of independent hospitals is shrinking, and in fact, is predicted to shrink even further during the next 5 years. Health systems are more and more trying to portray themselves, or not portray, actually provide population management. In order to do that, they need deep infrastructure supported by technology, and frankly, all of that costs a lot of money. And training people to operate all of that takes a lot of time and costs a lot of money, as many of you know that have had to go through that training. So in fact, these organizations believe that they will be better prepared to be consolidated. Interesting thing about healthcare is it's different in so many places. It's so hard to generalize about it. The rural area is so different than the urban area. The Midwest is a very different character than the South. Even the dietary habits of people across this country are significantly different. So it's a very hard thing to generalize and say in one given place that something is right or wrong, which makes setting policy for it something that is of interest and something that needs to be discussed. However, many people say that the hospitals getting together is in fact driven by wanting leverage, and wanting leverage with ever larger payers. I commend you, if you have not seen it, to the JMA, the Journal of American Medical Association editorial that was published on October 6th. Dr. Torrance was kind enough to bring that to my attention. Well worth reading if you have not read it. And they note some serious questions about the impact on quality, access, and price. Let's talk about physicians. Doctors and medical groups continue to remain independent, although new doctors coming out of practice more frequently choose to join larger organizations. Medical groups, to compete and even just to function, require technology of their own. It's almost de rigueur to have electronic health records. It's almost de rigueur to have electronic practice management systems. You need people to maintain all of that. You need managers that understand that technology, that can negotiate with payers and can help negotiate with provider organizations. So indeed, the physician groups find that they need a lot more infrastructure than they needed ever before. And I can tell you, when my little father started his private practice here on the West Side in the 40s, he hung out his shingle and used a single bank account for both the house and his office. Times they are changing. So what we see today is medical practices need a great deal of sophistication, and not everybody's willing to do that. Not everybody is willing to put up the money that it takes to operate all of that. As a result, physicians have joined groups, medical groups have been acquired, and many health systems, as well as some of the payers, eye medical groups as very, very valuable acquisitions. And as such, there have been a number of acquisitions in the medical area. So the Health Forum. What are the implications for quality of care, patient access, and the cost of care as a result of mergers? Are mergers limiting competition? Are they impeding innovation? How can the public be sure that physicians are free to recommend both appropriate and timely care from the best source of care? How do patients and employers financially fare as a result of these combinations? Because after all, the patients and the employers are the ones that are, along with the government, that are footing the bill. And finally, what is the role of government to protect the public's health and the marketplace? Our speakers. We'll lead off with Jack Resnick. It's a pleasure, by the way, to have all of these speakers. Can't tell you how thrilled I am that they were able to come down. All of them have traveled to this meeting. Jack Resnick is an elected member of the board of the American Medical Association. He's a full professor and also in the School of Medicine at UC San Francisco. He also is appointed as a health policy professor at UCSF as well. He did his undergraduate at Brown in public policy. He did his medical degree at UCSF. He is a very interesting fellow, and we will lead off with Jack in just a moment. Anthony Wright is a firebrand. That's what my friends tell me about you, Anthony. He is a consumer advocate with deep credentials in consumer advocacy. He leads the Health Access here in California, a coalition of consumer rights groups. He has worked in Washington, D.C. Once upon a time, I think he was in the East Wing, working for Vice President Gore when he was in the White House. He is a graduate of Amherst, magna cum laude, a dual degree in both English and sociology. John Wygon, lawyer, Federal Trade Commission, person on healthcare mergers, is also going to join us tonight. John has been with the FTC for a number of years. He did his AB at the University of Chicago in economics. He did his JD at the University of Illinois. He is an expert in antitrust. I've seen John speak many times. He's been involved in a number of important physician cases. I note that he was involved in the North Texas physician specialty case, which is particularly known to those of us that represent medical organizations because of its precedent-setting authority, and it was a case that, if I recall correctly, the FTC won. And so, and the docs spent a hell of a lot of money in that case, by the way, John. So we're very, very pleased that John would come. I do want to make one special comment about John. John is here at our invitation. His views are just that. They're his views. They're not to be interpreted as the views of the Federal Trade Commission. Same could be said for Jack and Anthony. We'll let Anthony speak for Anthony. Okay, so without further ado, Jack.
Thanks, Tony. It's great to be here. I will note that when you invited me, you didn't tell me I was going to be competing with a presidential debate and a World Series game, but I'm extremely pleased that there are enough health policy nerds to actually nearly fill this auditorium on how those things are going on. So I have no traditional financial disclosures to make, no conflicts of interest on that front. Obviously, I'm a physician. I practice medicine, and I guess that's a conflict in some way. My one disclosure I would make is that I'm not a healthcare lawyer. I'm lucky to have one on the panel, so take that for what it's worth. So I think as we start thinking about mergers among health plans, there are two very different narratives that we're hearing during this debate, particularly with these two big mergers facing us. You're hearing a narrative from insurers that are really claiming that consolidation is the answer and a necessary thing in an era of changing healthcare. As physicians, we have a very different point of view of that, and we actually think that competition is crucial, that it's really important for premiums that individuals and employers pay for healthcare, that it's incredibly important for patient choice, and that it's incredibly important for the quality of healthcare. Tony asked me to start off by talking a little bit about just sort of our view of what the healthcare marketplace for insurance looks like right now, pre-merger, without these two mergers moving forward. And the AMA actually has been, for the last 14 years, coming out every year with an updated study. I actually brought a copy if anybody wants to look at it, called Competition in Health Insurance, where we actually use the methodology developed by the FTC and by the Department of Justice that helps us define what concentrated markets are and apply that to healthcare markets around the country to look at how competitive they are. Our findings have been disturbing for many years in a row now to many of us. They essentially show a collapse of competition in the healthcare marketplace. In the last study just published this year, we saw that 70% of the metropolitan areas around the country have highly concentrated healthcare markets. 89% of metropolitan areas have a single insurer with a greater than 30% share of the market. Looking at state-level markets, and these are combined PPO HMO markets, but we've done it separate and combined, and the results aren't all that different. 14 states have a single insurer with more than 50% of the covered lives in the state. 46 states have two insurers with more than half of the covered lives in the state. So we didn't look at Medicare Advantage, but we think that's a fairly separate market. And the Commonwealth Fund actually has looked at Medicare Advantage, and their findings are that 97% of the metropolitan areas in the country have highly concentrated MA markets. What does this mean? Well, it means for patients and employers higher premiums. We actually have a series now of good studies and accumulating data looking at previous mergers and the effects of those mergers, and they consistently find that premiums have gone up compared to controls after large mergers. There was a new study just published this year looking at the exchange marketplace and what would have happened if United Healthcare had been more participatory in the first year, and actually found that in the exchange marketplace, premiums would have been lower with more insurers in the marketplace. For physicians, and the world where I live, working in this marketplace, it takes a very, very low amount of negotiating power that doctors currently have, and potentially makes it even lower to have these mergers going forward. A lot of that we see through unfair contracting. So about 61%, even though more physicians coming out of training are joining larger groups, 61% of doctors across the country still are in groups of 10 physicians or less. Very hard for a doctor in a group of 5 people, 8 people, to negotiate aggressively with a large payer. It also means that the payments for physicians are reduced, and that actually has a direct impact on access for patients. We can talk more about that tonight. And it makes it tougher for doctors to invest at a time when we're buying electronic health records, trying to make more coordinated practices, trying to improve the quality of care. It also makes it tougher for physicians to advocate for our patients. When the health plan director is several states away, not in our community anymore, when one payer has 40% of your patients and you feel nervous that advocating too strongly for a patient in need to get something off a formulary might get you kicked off a plan, it gets tough. And then something I have a little experience with, which is narrow networks. So another consequence is that large, powerful, dominant insurers are able to select certain physicians to participate in their networks and kick out other doctors. Our experience has been that it's largely been the most expensive doctors, which may include a few wasteful physicians, but it's because they're not risk-adjusted data, it often includes the physicians taking care of the sickest patients. We did a study you could only have a bunch of very eager medical students do, where we had medical students call, I'm a dermatologist, so we had them call several thousand dermatology offices listed in Medicare Advantage plans pretending to be patients needing an appointment for medical derm. This made a lot of media, so you may have seen something about it, but at the end of the day, we found that about a quarter of the people listed in those directories weren't even real, in the sense that they were duplicates, like with a middle initial versus not an initial. Let's just pick one of these insurers, not to pick on anyone in particular. I pulled the data from Orange County, which, we're not in Orange County, but we're close here. 283 dermatologists listed, 147 plus 3 were actually duplicate listings. We couldn't find 10. 18 were deceased, retired, or moved away. 11 were in the plan. 8 weren't accepting new patients. 16 were only doing surgery and not seeing medical derm patients, et cetera, and you're left with about 23% of them. So not only are insurers narrowing their networks, they're not being entirely honest about who's in them. The funniest moment for me of this entire thing was a major chief medical officer for a major national insurer called me and was arguing about the data and said, when you listed somebody as dead, because you called the office and the receptionist said they had passed away, did you call the Social Security Administration to confirm that they were honest about that question? And I was like, if they're on a beach in Venezuela drinking martini to this patient, they're essentially dead. So another thing that we've done at the AMA is taken this research to the next level to look at these 2 large mergers that are being proposed right now and the impact that they would have on market concentration. And the effects are pretty stunning, in particular the Anthem-Cigna merger. It enhances market power in 10 states and in 85 metropolitan statistical areas. This again using the FTC's own approach. And looking at the Aetna-Humana merger, it enhances market power in 15 metropolitan areas within 7 states, combines 2 of the largest 4 Medicare Advantage plans. We're just extremely concerned about this. And as Tony alluded to earlier, there is a bit of a national market in health insurance in some ways, in that very large multi-state employers are working with these 5 large companies that are left. And if these 2 mergers go through, we would be going from 5 to 3. A pretty substantial difference. So finally, before we move on to my fellow panelists and then eventually on to the discussion, what does the AMA think we should do about this? So the first thing we're calling for is very careful scrutiny. We think that and hope that the Department of Justice and the FTC are doing a good job looking into these mergers, and we would urge them to apply a high level of scrutiny. We saw in the 2010 proposed merger in Michigan between 2 large plans the FTC basically saying that was something that they were highly concerned about and were planning to bring suit against. And that one was actually dropped and never moved forward. And we hope that same level of scrutiny would be applied here. Some people have said, well, we should just let these mergers, go through, give it a try, see what happens. There are post-remedy mergers we could try. That has really not been our experience. Our experience is that you can't unscramble the egg, and that by the time you're down to 3 insurers, it would be very tough. The barriers to entry, we can talk more about this as well this evening during the discussion, for new insurers moving into a marketplace are very, very high. But I think we don't stop there, because physicians are innovators, and we like to think about better ways to do things. And we actually think there are a lot of ways that we can foster increasing competition in the insurance marketplace to encourage more market entry. We can talk more about this tonight, but you're seeing a lot of interesting things going on, some good, some bad, around alternative payment models, ACOs, and a lot of innovation on the physician side around care delivery and payment models. Those occasionally run afoul of some of the antitrust rules and laws that exist there. There's been some relief that's been given on some of those rules for care coordination. But we think that needs to be further clarified and made easier. It's very tough for physicians and small practices to work their way through those rules. The ACA brought us a ban on physician-owned specialty hospitals and ambulatory surgery centers. We actually think that's counterproductive to having more competition in the marketplace, particularly at a time when there's a lot of hospital consolidation going on. We're also concerned about certificate of need programs that were initially intended to try and reduce costs by making it harder to have new healthcare facilities in communities. But again, at a time of such market consolidation, we really feel are making it harder to have more competition and new entry into the marketplace. So I look forward to this evening's discussion and hearing from my fellow panelists. And again, I really appreciate the invitation to come down and join you all tonight.
Okay. Anthony Wright.
So good evening. Again, my name is Anthony Wright. I'm the Executive Director of Health Access California. We're the statewide healthcare consumer advocacy coalition, working for nearly 30 years for the goal of quality, affordable healthcare for all. This is not my conflict, this is my avocation, so I am speaking on behalf of my organization, as well as for myself. And as a consumer advocate, as a patient, as somebody who has worked on these issues with regard to both work around the HMO Patients' Bill of Rights, working as the lead organization in California on the Healthcare for America Now campaign to pass the Affordable Care Act and to now implement it and improve it in California, and on a range of budget issues. And then one of the things that we've been very active on is on these various mergers. One of our also goals is to be a resource to groups and to individuals about how they can get more involved in health policy. And so we have a number of resources on our website, on our Facebook, on our Twitter. If you're hashtagging tonight, we want to make sure that people are engaged in these decisions, because this issue is about you. This is about the care that you receive. We're already in the middle of this. It's been here in California. We really haven't had a range of major health insurance mergers for about 10 years, since the Anthem WellPoint merger and the Pacific Care merger. But now we've seen several. One was just approved a couple of weeks ago, Blue Shield and Care First. And then, as was already mentioned, several big ones, Aetna, Humana, Anthem, Blue Cross and Cigna, and Centene Health Net, all of which are pending right now. These are big billion-dollar businesses merging, and the question is, what is our concern? What's our piece of this? Why do we care? First of all, the key thing is that it's our money. That when a health insurance insurer buys another insurer, how did they get that money to begin with? How did they build? In many cases, they built up in what some might argue are excessive reserves, and then are able to then use that money to expand their market power by buying an insurer, but that's money that was extracted from our premiums. In some cases, for those insurers that are nonprofit, like Blue Shield, those might be charitable assets. So there's a very specific way that it's our money. But even to the extent that it is a for-profit, it is something that they're using money that they got out of our premiums when perhaps that money could have been used to reduce rates to otherwise provide better service. The obvious concern with regard to all of these issues is the issue of choice and competition. If there's less players in the market, what does that mean? What does it have an impact on cost? How does that have an impact on quality? And then the thing that I want to add to this discussion between our two other speakers is the issue of quality and corporate behavior. That in fact, how are these insurers doing in terms of abiding by current consumer protections? How are they doing in terms of what services they provide? And in fact, if they're not abiding by these standards, which many are not, then really we need to insist that if they want to get bigger, they need to get better. So we know why health coverage is, health insurance mergers are probably a good deal for the insurers, bigger market power, etc. It's unclear why they're good for consumers. There's not a lot of evidence in the literature about the documented benefit of insurance mergers for consumers. It's just not there. You can make the case that it's even, that there might not be a big difference, and maybe some people make that difference, but there's not a lot of evidence that it's actually an improvement. There's never been a merger where health insurance rates has gone down after the merger. There just hasn't been. And so I think we need to, as consumer advocates, as patients, we need to start to say, is this an actual positive benefit in moving forward? With regard to some of the big national mergers, as was stated, there are very real issues with regard to concentration. These are major national issues. As we mentioned, there is greater concentration in certain markets than in others. California, even though we have a concentrated marketplace, actually has more competition than in other states. And so these issues are not as acute in California as they are in some other states. That's not to say that there aren't real issues, but they are in, but I would say that if you were to say the top 10 places where the Anthem-Cigna or the Aetna-Humana mergers provide the most problematic issues with regard to antitrust, I don't think that those are in California. That's not to say that there aren't very real issues, and again, it's very specific marketplaces. So, for example, nationally, on Medicare Part D prescription drug plans, on Medicare Advantage plans. I mean, just look at, if you look at the Medicare Advantage marketplace, for example, you have these major players, and these pieces of the pie, consolidate pretty quickly when you look at some of the mergers that are happening, that are proposed. So I think that that's a big issue that needs to be resolved. But here in California, an analysis by one firm showed that there was going to be reduced competition and increased concentration in specific counties and also in specific markets, including Medicare managed care in a small group market in certain areas in certain ways, and that needs to be investigated. But I really want to talk about the fact that overall, the reason why we care about competition is that this is the premise of health reform. The premise of health reform was not the government takeover that some had talked about. It was a big deal, as the vice president said. But it was based on the notion of market choice and competition. It was based on the notion of having a more sensible market when we didn't have one. And so you can't have a market if you don't have multiple insurers competing, and so this reduces competition, it reduces care. And California has taken incredible steps to go early, to go better with regard to implementing it, including with regard to having an exchange that negotiates on behalf of its residents. That's a big deal. We're only one of 3 or 4 states that do that, where Covered California is actually a negotiator negotiating on behalf of the 1.3 million Californians. But if Cover California is in a tougher place to negotiate with a plan if there's only two or three plans willing to play in a certain market, in a certain area. That's not the case in Los Angeles, but that is the case in certain markets in California, in the north above Sacramento, in some of the Central Coast. And so that's where, again, we need some of those choices, because otherwise it's a lot harder for Cover California to have that negotiating stick. One final thing, there is an argument out there that, in fact, the big driver of healthcare costs is not health insurer mergers, but provider consolidation. And you see that, for example, with regard to the much higher rates in Northern California than Southern California, and that's because of some consolidations. Some people would say, it's just one word, Sutter. But I actually would agree with that. That actually is probably a bigger deal. However, I would not take the next step, which is to say we need to let insurers merge to negotiate with these hospital behemoths. In fact, I'm not sure that we have the regulatory structure in place to make sure that even if these bigger insurers are able to negotiate a better deal with hospitals that still have in the catbird seat, because if you need a hospital in a certain area, then they're the game in town, regardless of what size the insurer is. But then, do we have the regulatory mechanism to make sure that those benefits flow to the consumers? I'm not sure we do in California. So our basic thing is that, yes, provider consolidation is an issue, but two wrongs don't make a right. That it's not one or the other. So what I want to say is, the issue that I wanted to just convey is the work that we can do here in California. There's going to be an antitrust review, and our next speaker is about to talk about it. But let me talk about the state review, where we have two regulators that will be looking at this. We're the only state in the nation that has two regulators, the Department of Insurance, which regulates a relatively small part of the market, about less than 2 million lives, and the Department of Managed Healthcare. But both will have a crack at some of these mergers in terms of reviewing. Department of Managed Healthcare will do a financial review to make sure that it's a viable plan financially, there's tangible net equity, the organizational structure, those types of issues. But they'll also do a licensing review. So there'll be a notice of material modification that must be filed, and they will look at not only organizational corporate structure, but the healthcare delivery system changes, such as provider networks. We do expect the Department of Insurance just announced today that there will be a public hearing on November 17th on the on the Centene HealthNet merger, and then the Department of Managed Healthcare said that they're going to have hearings in early 2016 on each of the mergers. And so we think that that's the opportunity for consumers to really engage in making sure what is the demands that we have to make sure that if they get bigger, they need to get better. On network adequacy, on provider directories, what was stated about provider directories is absolutely right. We were able to pass a bill this year to require accurate provider directories, but this is something that needs to be done, and the merger process is a good way to impose those kinds of requirements on, but also quality, complaint grievances, etc. One thing in specific is the Blue Shield Care First merger. Since it just was approved, let me just use that as an example in my last minute or two, which is it was just approved a couple of weeks ago by the Department of Managed Healthcare with 25 undertakings or conditions on the sides of the merger. One was investments of about $200 million, $140 million increase in their foundation giving, but also money for encounter data, so there's more transparency in what Blue Shield and Care First did, as well as improvements and funding of consumer assistance programs around the state. There was a commitment to improve what was below average quality ratings for Care First and Blue Shield in key areas, and then also a requirement to clean up its inaccurate provider directories. Blue Shield was, the Department of Managed Healthcare did a review of both Anthem Blue Cross and the Blue Shield last year and found that 25% of those provider directories were inaccurate, and that needed to be addressed, as well as access to specialists and Care First network. That was a problem. Consumer advocates actually urged additional conditions that we did not get. One was the issue of charitable assets and protecting those charitable assets as a nonprofit. I do think that in some of the new mergers that are coming down, another issue that will come out will be one about in and out of state operations and assets. Is the medical director here in California? Is the customer service center here in California? Do the regulators have the ability to inspect, to provide guidance, to have power over the independent medical review, medical utilization, those functions of the insurer? That's something that's going to be required, as well as assets. I remember one of the big fights previously in the merger 10 years ago was the issue of when Anthem WellPoint merged. Were those a lot of California assets just going to get basically flown to Indianapolis, the headquarters there? So that's another type of issue. But we also, as consumer advocates, urge for additional investments in transparency and access for the uninsured in rural areas. We thought it was appropriate that these health plans commit to not go forward with unreasonable rate increases for the next 5 or 10 years, because right now we don't have that power in our current law to regulators can review rates but not deny them if they're deemed unreasonable. But we thought it was appropriate for the insurers to make that commitment, and then other issues with regard to quality and equity and customer service. So again, what I'm suggesting is that there is a place for, this is not just for the antitrust lawyers. This is something that we as consumers can get involved in and to take the next step to make sure that our health system actually works for us. We know that health mergers work for insurers. We need to put in place the conditions and the undertakings to make sure they work for patients as well. Thank you very much.
Counsel? John Wigan.
I also want to extend my thanks to the folks here at UCLA and Tony for putting the program together and including me as an attorney from the FTC as part of it. And I will state or restate the disclaimer that the views I'm expressing here tonight are my own and may not comport with the views of the commission as a whole or any individual commissioner. So we're all about competition. A lot of competition tonight. We're over at the desk. They're projecting in the World Series the Mets to win, and they're projecting Kasich to win in the debate. Spoiler alert: we've already spilled the beans on that. I want to give just a little bit of background on the Federal Trade Commission and antitrust law in general. The key thing to understand about antitrust law is that antitrust law is concerned about protecting consumers through competition. Antitrust law is not concerned about protecting competitors. The big difference. The Supreme Court has said this over and over, and antitrust cases keep cropping up under the theory that some competitor has incurred some harm and wants to use the antitrust laws to remedy that problem. And every time the answer is, you may have a remedy, but it's not here. So the key thing is we thrive on competition, and we want the marketplace to be competitive. Interestingly enough, the enforcement of the antitrust laws is itself very competitive. There are two federal agencies that have almost precisely the same jurisdictions to enforce the antitrust laws. There's the Bureau of Competition within the Federal Trade Commission, and then there is the Antitrust Division within the Department of Justice. If that weren't enough, there are also state attorneys general who have jurisdiction to enforce both state antitrust law and to bring, in most states, they have authority to bring federal cases using the federal antitrust law in federal court, state of California versus merging parties, insert their name here, in federal court. And not to be forgotten is that private parties can bring suit civil cases in federal court under the antitrust laws if they have sustained antitrust injury. So if they have been injured as consumers, they can bring a private case in antitrust, based on antitrust in federal court. They can get 3 times the actual amount of damages. They can bring the case as a class action, and their attorneys can collect attorney's fees, reasonable attorney's fees, that is. Spoiler. So the enforcement of antitrust laws is a very competitive enterprise. So you might want to know how we get our cases. I mean, how do we decide what to do? Well, there's a number of ways in which we get cases. First of all, if parties are merging and the value of the assets in the transaction exceeds $76 million, then the parties must submit a pre-merger notification to the Federal Trade Commission and to the Antitrust Division of the Department of Justice. So that covers a lot of mergers, but clearly not all mergers, and particularly of interest to us is mergers among physicians are rarely large enough in their assets that they're going to meet the threshold and become reportable transactions. But that doesn't mean we don't find out about them, because we have lots of ways about finding out about things. We have phones. My phone number is 415-848-5174. We have email. My email is jwigan@ftc.gov. We get complaints. We get complaints mostly, gratefully, from competitors. I buy this product, and my two favorite alternatives have just merged, and they're announcing a price increase. Can you do anything about it? Yes, we can. Now, that's a typical format for a complaint, but they're not as much fun as this particular format for a complaint. This is the dissident insider complaint. I was at a meeting last night of my physician organization, and they said that they were going to start jointly negotiating price with health plans on behalf of all of us. I said that I thought that was a violation of federal law. They told me to shut up because this was a good idea and we'd all make more money. So, can you tell me, was I right or not? We get a lot of complaints like that, the dissident insider complaint. We also, get this, we also read newspapers. You know, and trade journals and stuff. And one of the things that is really funny is that some people kind of self-report their antitrust violations. You wouldn't think they necessarily want to do that. But there's a particular organization, I'm not going to mention any names, but they were soliciting physicians to join their organization. And they said, look, you know, if you join our organization, here's what we'll do for you. We're going to pool your negotiating power with a whole bunch of your competitors' bargaining power. And guess what? You won't have to do anything different. You can just practice medicine the way you've always practiced and make more money because you'll have all this leverage when we group all the negotiating power of your competitors with yours. You know, it's just amazing. Or the other one is reporting a merger in the press, and one of the presidents or chief executive officers or one of the parties to the merger said, the reason we're doing this is because we're going to be able to raise price. So self-reporting of antitrust violations in the press is a way that we get cases. Now, once we have a case, what do we do with it? Well, there's really 2 kinds of cases in antitrust law. There's certain conduct under the antitrust law, which is what we say per se illegal, right? Which means if you're doing it, you're wrong, right? It doesn't matter whether the government or the plaintiff in a case can show effects of what you've done, but what matters is you've done it. So if you have agreed with a competitor on price, that is per se illegal. It could be, you know, 2 doctors in a marketplace of 100 doctors. If the 2 of them have agreed as to what price they're going to charge, and they're competing with each other, it may not have any practical effect. It's still illegal. All right? There's certain categories of offenses that are legal. If you've agreed to divide the market, we have say 2 groups of radiologists, and and they say to each other, look, we're tired of this competition. You practice exclusively at Eastside Memorial Hospital, we will practice at Westside General. You won't come under our tier, per se illegal, all right? So there's those kinds of cases. The other kinds of cases are rule of reason cases. They're cases where the government needs to show that anti-competitive effects are likely to result from the arrangement. Classic case of a rule of reason category is a merger case. When we look at a merger case, we have to go through a particular structural analysis to determine whether the merger is likely to result in increased prices or decreased output. Exactly, all those two things go together. We need to establish the product market that's going to be affected by the merger, acute care hospital services, or primary care physician services, or radiology professional services, or outpatient surgery services. All right? We have to establish what the product market is. And we have to establish what the geographic market is. If an acute care hospital in Houston is buying a hospital in San Francisco, it's pretty unlikely that there's significant competition between these two facilities. So there has to be competition between the parties for there to be an antitrust case. So we need to define a geographic market from the point of view of consumers. Where can the patient reasonably turn for services? We establish that geographic market, then we can calculate market share. We can determine whether the market is in fact going to be highly concentrated after the merger. And then we have to have some kind of coherent theory of how that merged entity is going to be able to raise price. They're either going to be able to do it through a unilateral action, so big, and the market has limited excess capacity, so that the merged entity can unilaterally raise price. Or alternatively, they can coordinate with other providers in the market and raise price through coordinated interaction or increased probability of collusion. So we have to have a coherent theory. Now, factoring into that would be issues such as whether there are efficiencies, because after all, if the efficiencies are really large, consumers might, instead of losing, might actually benefit. And we have to look at factors like entry, because market share is irrelevant if entry is easy. A famous case outside the healthcare industry several years ago back in Las Vegas about movie theaters. A single company had gradually accumulated 90-something% share of the industry in Vegas, and the DOJ brought a case, but the problem is there's no entry barriers into movie theaters in Las Vegas. By the time the case got to trial, the alleged monopolist was stuck with all the theaters with dummy floors and sticky seats, and his newfound competitors had these shiny palaces of cinema, and his market share had collapsed. So having 90% market share does a company no good if there are no entry barriers from the point of view of being able to exercise market power. So I think with that, we will turn things back over to Tony.
Okay, I'm going to start out with a question, but let me tell you how all this works. You raise your hand, you identify yourself, we'll give you a mic, you identify yourself, you try to state your question slowly so the people that are watching via video, or rather web streaming, can hear. And then if you want to direct it to the panel generally or to a specific speaker, please identify the speaker. So I'd like to begin first, Jack, with you. Jack, what is the impact, if any, of mergers on innovation in healthcare? You mentioned that, but can you explain more about that?
Yeah, I mean, I have have some real concerns around that. I think there's a lot of innovation going on right now in healthcare, right? It's a time of huge flux after the ACA unleashed a lot of interesting things that are going on across the country. We're seeing new care delivery models. We're seeing new bundled payment models. We're seeing new shared savings projects between physicians and healthcare systems and Medicare. When you look at where those things are coming from, a lot of them are coming from physicians and providers with the help of our healthcare attorneys and other people who are helping us to figure this out. They're not largely coming from plans. Health plans are doing a few interesting projects. It's not to say that they're not, but I don't think that's the source. And I think to the extent that they become larger and larger, and it gets tougher and tougher for physicians to be in a position to be able to negotiate with them, my worry is it'll constrict that. I mean, we have experience, right? A lot of physicians have experience with communities where the plans are very large and control a large percentage of the market. And my own experience of that in dealing with a very large payer is not one of innovation from the payer end. I just have to be honest. Their version of innovation is sending me a fax that says, do you know your patient Jane Doe is on a drug for more than 2 weeks that was only approved for 2 weeks of use when actually nobody's used it for less than 2 weeks in 20 years. We've had fax machines I don't know, since I was a kid, so I mean, that's not innovation. We see them narrowing networks and kicking physicians out. We see them asking for prior auth. And again, we have a huge problem with drug prices. I understand the situation that they're in. That's a whole other seminar, I think, that I come back for. But my sense is that we need physicians and providers to be out there doing innovation, and I think this is not helping.
Okay, we will open it up. Yes, sir, down here in the yellow.
This is a question for Mr.
Could you state your name for us?
Oh, yes, my name is Mike Rao. Excuse me. You mentioned bigger and better, but isn't that a false consideration? Because they're already so big, and the bigger gives them so much more lobbying clout, so much more regulatory capture, so much more revolving door, so much presence in the halls of Congress, that when they make nice during this change, they can unmake their niceness later.
It's a fair point. I think regulators have basically 3 options: approve, disapprove, or approve with conditions. And so, and it's often the case that
Sorry.
something I said.
We're in the dark.
So I think we want to make sure that any merger is done that is in the benefit of the patients and of the health system in general. And there's a lot of different ways to define that. I tried to sort of lay out a couple of different metrics and qualities to put forward. I certainly think that is the case, and it's certainly true both at the insurer level and at the provider level, that if a regulator puts too many conditions on it, the merging parties could walk away from the deal because it doesn't work for them. We just had one actually earlier this year, Daughters of Charity Hospital System, which has a couple of hospitals here in SoCal, but also several in the South Bay, was trying to be taken over by Prime Healthcare, and the Attorney General, in our view, rightly imposed a number of conditions, including requiring that the emergency rooms and key services stay open for 10 years and some other things. And Prime walked away from that because it just was not, because maybe perhaps they were planning to do what they said publicly but didn't put it into writing. So I do think that sometimes the conditions matter to the extent of to that point, and even with regard to the insurer piece, on the insurer piece, these conditions do have the force of law, and the regulators have the same tools at their disposal with regard to everything from fines, issuing corrective action plans, to removing of the license. At the end of the day, what the Department of Managed Healthcare, what the Department of Insurance is approving is a change in the license, and that is ultimately Now that's it's very hard for a regulator for a regulator to say, we're not gonna let you merge at all, or to say, you're acting so badly that we're gonna take your license away. That's sort of like the nuclear option. That's a very hard politically for the regulator to do. It's hard practically, it may be a situation where there's people depending on that insurer, depending on that provider. So I think that they don't do that lightly. I want to be clear that if we are going to go forward, we need to make sure that we have some strong standards in place and make sure that they're enforceable. And so that's where we're coming from it. But it may be justified that if they cannot meet the conditions, then don't go forward with the merger. And there certainly are, especially on the antitrust side, some mergers that are just totally inappropriate, that should be opposed.
You're not answering my question. I'm asking, won't that magnitude give them so much lobbying clout? Won't that, excuse me, you're not answering my question. I really asked you, won't that increased magnitude give them so much lobbying clout that they can come around and do this regulatory capture? We've seen this happen with Wall Street. We see this with a lot of big businesses.
Fair point. I guess so you're asking a political science question.
And if you like big, why not just go Medicare for all? Go as big as possible.
Well, I'm for that. My organization's for that. I endorse that. I'm not sure that would have that might be an interesting debate to have with my colleague. But, I think that that's appropriate. I'm sort of talking about the practicality of these mergers in front of us right now, but there are steps that we can take toward a different form of healthcare system, including a Canadian-style single-payer system or another system. Absolutely.
So I would make the point that the mergers we're looking at right now, the two big ones in particular, are so huge that I don't believe there are divestments you could require from a regulatory standpoint that would make those mergers non-revenue markets. I think they're so giant. And the number of other companies in a lot of these communities are already so dominant that there aren't the players there to even divest to in some cases, in many cases. So I share the concern that there is no way for some of these giant mergers to come together in a way that ends up good for consumers or providers.
John, would you comment on that too?
Sure. We have some experience with merger cases coming to settlement with either structural remedies being divestiture when that's possible, and conduct conditions. And our general experience, I don't want to comment on any specific cases, particularly ones that are pending for federal review, but our general experience with conduct remedies is that these are very unwise because they tend to lock in a particular state of the world that exists at the time the merger is consummated, and the world changes and the parties are stuck with, or the consumers are stuck with conditions that were seemingly appropriate at the time, but the world changes and it kind of freezes things in place. So it's very much opposed to innovation. With respect to consolidation of health plans into a single payer, or consolidation of providers, the foundation of our economy is built on competition. And if we don't have competition here, we're going to undermine one of the chief attributes of our economy.
Interesting. Okay, way in the back. Please identify yourself as well as what you do.
Hi, my name is Seth Gilroy. I'm a student at UCLA Extensions. And my question is for the gentleman in the middle. You mentioned that there's no evidence that mergers have been able to actually lower the cost of healthcare. I'm wondering if there's any evidence that suggests that mergers have prevented the cost of the premiums from rising. Naturally, you would think that the reason why someone merges is because it's a struggling entity, and so they're trying to come together to bring resources so they can do business better in a competitive market. I'm just wondering if that has had any effect on capping premiums from rising in the healthcare industry?
I'm not aware of it. And again, I think that there is at least an argument that depending on the situation, that there may not be much of a difference between, 6 players in the market versus 5 players in the market. But I think that clearly there's an argument that in a case where there's a major consolidation of two major players in the market, that actually has a negative impact. I have not seen, I can't say that I've done so thorough a review that there's not something out there somewhere, but something where that it has that it actually reduces the cost to have less competition and less players in the market.
To the contrary, we actually do have good evidence that
Right.
premiums go up after mergers. So this has been looked at in the academic literature around the United Sierra merger in Nevada. I don't have the study right in front of me with the numbers at my fingertips, but the conclusions there were that premiums actually went up compared to what they would have without the merger. A similar study of the Aetna Prudential merger. And it's interesting because the insurers were found to use their monopsony power because they don't just have, when they get really big, they don't just have the power to raise their prices on the output end for consumers and employers, but that also gives them more negotiating power with providers. And their argument sometimes is that, well, we're going to use our bigger size to negotiate better rates with providers and then pass that money on to consumers. That has not been the evidence at all. The evidence has been that they do reduce rates for providers and then raise premiums for the purchasers. So we don't see that when they get larger, all of a sudden there's a big windfall for consumers.
John?
The structural model for the kind of outcome that you're looking for would be some of the mergers that we saw maybe 10 or 15 years ago on the health plan side, where health plans that did not compete directly with each other, served different regions, or competed only in a trivial way, merged to get administrative economies of scale, but it didn't reduce competition in any meaningful way. So if you wanted to be looking for those kind of issues, that's just kind of structure you'd be looking for.
And just one last thing, I think that, again, the argument that we've heard, and one of the proponents is Peter Lee, who's the head of Recovery California, who has done impressive work in setting up the exchange here in California, but he had an op-ed in the Wall Street Journal with regard to, if we have so much consolidation at the provider level, shouldn't we might want to look at some ability for the insurers to be able to basically bargain a better deal. But again, I just don't believe that we have the regulatory structures in place to make sure that even if they were able to do that, that would then be passed down to the consumer. For example, in California, we have rate review but not prior approval rate regulation. If an insurer has a unreasonable rate, they can still go forward with it. So the Department of Insurance, the Department of Managed Healthcare can deem it unreasonable, and sometimes the insurer then rolls back or readjusts their rate accordingly, but sometimes they just go forward with it. And so we just don't have the regulatory structure in place to even if they were able to get those efficiencies, to make sure those efficiencies actually translate down to the patient level.
There's no reason for a firm in any industry to pass along the efficiencies that it's realizing unless it's facing competition.
Or regulation.
Now, regulation.
Yes, sir.
John, you mentioned a couple different
Whoa,
theories.
you want to identify yourself?
Oh, Kerry Wright, the Los Angeles Association of Health Underwriters. John, you mentioned a couple theories of law on antitrust law. One was that they did something, and then there was the other set of theories. And then Jack mentioned, well, he doesn't even think that they could divest to get within what would be acceptable. So if it seems like that second set, they weren't going to fare very well in a review on those set of laws. And then we have what Jack's saying, well, they may not even be able to do things to get within compliance. Why does it seem like these things are going to happen?
Well, I'm not in a position where I can comment on any matters that are subject to ongoing federal antitrust review. So, but just as a general matter, we reject mergers divest very easily the cardiac department from hospital B and say, we'll take the rest. So it's basically an all or nothing proposition. But if we're analyzing, say, an acquisition of a retail chain, for example, I've worked on a number of retail drugstore cases, you say, well, yes, you can buy that drugstore chain if you divest, the assets in certain cities where there's minimal competition, you can take the other ones.
When you look at the level of concentration of some of these markets, so I'm going to pick one that's not related to the current merger, but is in California, because we talked a little earlier about California has somewhat less problems with this, but actually we've got a lot of pretty concentrated markets here too. And this is, I'm picking one, but there are several of which you can say this about. So it's Salinas, is the metropolitan area, so a more rural area. WellPoint has 63% of the market, and Blue Shield of California has 23%. So if those two insurers were proposed to merge, there is no meaningful third insurer to take some of those covered lives, and there are several metropolitan areas around the state where that would be the case.
And I want to agree absolutely with that. Like, we have a big three or a big four in California: Anthem, Blue Cross, Blue Shield, Kaiser, and HealthNet. And if any one of those four were merged with any one of those other four, I think that would be a very clear. I don't know, our FTC colleague could say, you can't comment on hypothetical, but I think that would be a very clear violation. I think that the mergers that are being proposed are very clear in some other states. Here in California, because it's a big one with one that doesn't have a huge footprint in California. Although, as I said in my presentation, there are certain markets like Medicare Advantage and certain counties where even there, it could trigger that it shouldn't be allowed. And again, the question is it the gesture by region rather than the whole thing? That's another question. That how do you divide that up or not?
That would depend on the particular facts of the matter. One of the things that I'm sure would be relevant in a matter like that would be what other health plans are licensed to do business in a particular smaller city. And they may not be present in that city at the moment, but they might also be interested in taking certain contractual assets and entering that city through the acquisition of those assets as part of a spinoff to gain interest in the world.
We have seen examples, though, lately where licensed entities are trying to move as new entrants into markets where they don't have a lot of market share and it's not going very well. So, I mean, some of them have been newer players, but the insurers have argued, look at, they've taken the example of New York as this hit name, insurer, Oscar is the name of it. Well, I mean, it's lost half its revenues last year and had a $20-some-odd million loss. The co-ops, which were part of the ACA, we have many co-ops.
Yeah, they tanked.
Folding right now. So, I think even though there is the potential for entry or insurers who are licensed to enter, it is very tough in today's market to see that.
Ma'am, did you have a question? Yes, ma'am.
Thank you so much. Thank you. Thank you to all of you for the wonderful forum. And Dr. Glenna Tolbert, I'm clinical faculty, but I'm in private practice. I've been in private practice for about 13 years. And I take care of I function as a specialist as well as a primary care doctor to some of the most complex patients. They're paralyzed, brain injured, chronic pain, failed back surgeries, and so forth. And so it's hard for me to really, I could barely sit in my seat, as you could tell, squirming because of the obvious. It's almost like this story of the emperor has no clothes and everyone's pretending that he does. And it takes a little boy to say, but the emperor's naked. And so my point is this, and especially addressing the student in the back, what I've seen since the passing of the ACA, and my patients have seen it as well, is with the increasing market share, the insurance companies are just acting out. And what I mean by that specifically, yes, they're denying care. And so not only maybe are the premiums raised more for the patients, but they're denying care straight out where they didn't before. We all are seeing that it's harder to get medications approved. You're needing more and more prior authorizations. And then they have the gall even to ask for authorizations for office visits. These are for PPO plans. I'm a specialist. I'm double boarded and they're telling me, well, wait a minute, our nurse is going to review and get back with you and let you know. The nurse. And they say it, but they won't put it in writing. So when we talk about antitrust, to me, that's very clear that that is injuring our patients. And so my question is one comment, and two, that's to address the student in the back, the denying care. And thirdly, as a physician, I would like to know how I can be involved so I can speak to what's going on. We're on the front line. We're seeing patients cry. We're seeing them deny. We're seeing them suffer. And so, yes, it's very difficult for me to sit in my seat because it's not theoretical and it's not hypothetical. So what can we do as physicians?
Jack, we're going to start with you.
Well, I'm going to start by just thanking you for what you do. I think medicine is a calling. From time to time, we see some doctor in the newspaper who makes everybody think otherwise, but the majority of physicians out there are doing the hard work that you're doing, and I really appreciate it. There are a lot of things you can do. I think getting involved in your community, showing up in places like this, your county medical society, your state medical society, the CNA is deeply involved in this. We have consumer groups and others who I'm sure would love to have physicians involved. The AMA deeply involved in this and a lot of the issues that you bring up. So I hope you're a member of all those organizations. I feel your pain. And again, as I said earlier, cost is a huge issue. I mean, I do understand that we probably can't be in a world with no prior authorizations. And when I'm prescribing a new $40,000 biologic for a patient with really severe psoriasis or an $80,000 new melanoma drug for one of my melanoma patients, I get it that people need to make sure I'm using that appropriately, and we need as a country to think about those pharmaceutical costs and what we're going to do about that. But my experience a couple of weeks ago, I had a patient who was on one of these large national plans who actually wasn't that sick, as sick as many of your patients are, and needed 2 topical steroids for 2 different parts of their body. These are drugs that have been around since the 1960s. The generics are in the range of $20 to $50, and I was rejected for using 2 different drugs in the same class. It's a long story, but you have to have 2 for different body parts. I just decided I'm going to see what it takes to advocate for this patient, even though this is an inexpensive situation, because it was a patient who didn't have a lot of resources. And I had a day off when I was supposed to be doing some administrative work. And I spent 4 hours on the phone with this major national plan. I spoke to 21 different people across the country. I still, at the end of 4 hours, didn't have the drug approved. It was a new policy about not being able to do these 2 drugs at once. And I kept trying to say, can I get in touch with the clinician who's responsible for this disease? Now, at the end of the day, I'm lucky. I work with I meet a lot of interesting people around the country, and I get to the CMO of the insurance company. But it still hasn't solved my problem. And for the average physician taking care of sick patients all day, you can't spend 4 hours trying to get a $20 drug. So thank you for continuing to do what you do, and let's talk afterwards about ways to make sure.
The other thing I would say 2 things very specifically. One is that to the extent of this specific urges, I wanted to highlight the fact that this is, again, something that should not just be the domain of antitrust lawyers, that these mergers and other issues are something that are decided by representatives elected, that are appointed by legislators or governors or other folks. And so being involved at the Department of Managed Healthcare, the Department of Insurance, there will be hearings in each and every one of these mergers, probably both at the Department of Insurance and at the Department of Managed Healthcare. So us Californians were special. We get 2 cracks at the 2 cracks at it. The other thing is that on specific patient advocacy, we do have some good patient protections in place. The question is, do we use them and are they effective? The Department of Managed Healthcare has an HMO health line that can be used in this regard. If you call that number, they have the ability to get with the patient on the line, get the insurer on the line at the same time, a warm handoff, and have that and have the patient and the insurer on the call at the same time to see if that issue can be resolved or not. If they resolve it on that call, then it doesn't go into the book. So there's an incentive for the insurer to resolve it and resolve it quickly. I'm not saying that solves all the issues or even most, but it is an opportunity. And if it isn't, I'd love to hear more about how we can work it, because we're at the Department of Managed Healthcare every day trying to make that system better.
Plans are actually using that rule as an excuse sometimes. So when we call them now, they'll say, "Oh, because of the rules of the Managed Health Department,
Yes, sir, in the back with the glasses. Of course, that's half the room.
Thank you so much. Thank you so much. My name is Bruce June, and I'm an employee benefits broker. And so, I think it's interesting that there's no representative of the insurance industry on the panel. I think if you were going to talk about hospital consolidation, you'd certainly have somebody from the hospital industry talking about it. So, at some point, I would certainly love to be able to discuss some of the points that you've made. And one of the things that's interesting, and certainly the tragic aspect, we help a lot of our clients making sure that they get the benefits that they need, is that the conversation, because of the Affordable Care Act, has shifted from people who didn't have coverage to now having inadequate coverage. And so at least that's a positive aspect of the Affordable Care Act. I think that more people do have coverage. It may not be as comprehensive as we would want, but at least they have some coverage, and the doctors are getting compensated.
Your question?
Yeah. My question is that there are many aspects that go into the cost of health insurance. The cost of technology, the cost of new medications, the aging population, a whole variety of things. And so I'm just curious, in your study, how is it you were able to determine that it was in fact because of this merger that the cost got higher, because that seems to be one of many variables that influence the cost of healthcare. The other thing is that the market for health insurance is very fragmented. You have individual coverage, you have small group coverage, you have mid-sized group coverage, you have large group, you have national coverage, you have Medicare, you have Medicare senior plans, you have Medicaid. It's difficult to sort of lump all that together, so I just kind of wonder how you kind of flush that out, determine what your rates, how you came to the conclusion that there was no competition. And let me finish. And then the other, in terms of California specifically, with 33 million people, it doesn't seem as though there's that much, these mergers really have that big of an impact, because as Anthony rightly said, there's not that much overlap.
The study about,
Well, let's start with the cost of coverage question.
yeah, so your question about how were we able to attribute that. So I didn't do the study of those two markets, but they were comparing them to like control groups. So this was the increase in premiums compared to similar markets facing similar circumstances. So there were control groups, and this is not sort of a single out of nowhere study. This has now been done multiple times, and so I think that those are fair assessments. The middle question.
Well, it depends on the market, right?
Oh, your middle, right? It does. You have to be careful about what markets you're choosing. But those markets, it's interesting. We've got a lot of criticism for a lot of the work that's been done around this. Those studies have not been very criticized. You asked about who gets included. So we've chopped this several different ways. So we've looked at PPO markets alone. We've looked at HMO markets alone. We've looked at combined PPO HMO markets. One of the criticisms the insurers levied several years ago was that we were excluding some self-insured plans. We've added those in. What we try to do is look at plans that are interchangeable in a market. It doesn't make sense to lump Medicare Advantage plans in with those commercial plans, because patients obviously can't move. A healthy 35-year-old can't move back and forth between Blue Shield and Medicare Advantage. So, but the latest numbers are basically looking at almost the entirety of the non-Medicare commercial market.
Okay. Yes, sir.
Hi, I'm Richard Singerman. I'm adjunct faculty at Johns Hopkins in informatics. And I'm working on an initiative actually for bringing evidence-based medicine bio 2.0 to community healthcare workers and social workers, more to the community health, and looking at those models. One thing that strikes me about especially what Jack said is that I spoke with, as far as studying innovation in medicine for part of this project, I spoke with folks at Cedars who believe there's no such thing as an episode of care. And yet I went to a talk just a few weeks ago by a new company. It's basically negotiating, for lack of a better term, episode of care contracts between certain providers, like on behalf directly of employers. So, we've heard about, for instance, Lowe's will negotiate with Cleveland Clinic for an episode of care around cardiac surgery or taking care of a knee. So as these mergers happen, I really am quite concerned about the direction of innovation that are the payers just going to cut off these various innovation experiments, and are they just going to say, well, we're just going to pay for an episode of care, quote unquote, whether really such a thing really exists or not. So as we continue to learn and foster a learning health system, how is this merger really going to put a reverse pressure on that learning?
I think they are interested in bundled payments and other changes. I wouldn't say that they're in a wholesale way uninterested in that, but I think their thoughts about episode of care, you raise a really important point, are somewhat different than people living with episode of care. You used a couple of examples that are great. So 20 years ago, there probably were no episodes of care that we could logically make sense of, appropriately risk adjust for the level of sickness of the patients that a particular doctor or institution is dealing with, and create some carve-outs for some unusually sick situations and other things. We now have things where even from within the profession, we see physicians looking at, well, I'd like to create an episode of care and bundle payments for knee replacements. And here's a way I can do it that I think aligns the incentives properly, incents me to provide more quality care without being stuck in a very old system that only provides, rewards me for doing things, and incents me to try and keep the patient out of the hospital and from being readmitted. I happen to work in a specialty where it's a lot tougher to come up with those. And I don't think physicians in any way are folding their arms or dragging their feet about this. It just takes a lot of years to march through different diseases and accumulate the evidence that you need to do episodes, as opposed to an insurance company buying a piece of software that just supposedly tells them and defines an episode in ways that the physicians don't have the data, the hospitals don't have the data, and they have the proprietary data. It's very tough for us. So you raise really important questions, John.
By the way, we're working on a bundle exactly that on knees as well as hips. The bundle calls for doing patients, for example, hip replacement or an outpatient ASC, assuming that they're below the age of 65 and their ASA is 1 or 2. That's the anesthesia rating for the patient, and then sending them directly home. Much more cost effective. By the way, we've been doing it for a couple of years. Geisinger, more than 8 years ago on the East Coast, started doing hearts, same way, one price, and by the way, they warrantied them. So talk about putting your mouth. Dr. Flores.
Thanks for the introduction. Dr. Flores, I'm a family physician. So a question for the panel. Anthony, right, you mentioned that a lot of the mergers are, or at least alluded to it, that it's being fueled by the fact that there's new business, Medicaid expansion, covered California, opportunity to capture that market and then make a profit on it. I'm curious from all the three perspectives, how would single payer Medicare for all change the dynamic? Would it move the needle appropriately to merging for the sake of quality and efficiency as opposed to profitability, flipping the house?
Just address you, sorry.
Obviously, a single payer system, at least in its ideal or pure form, would not have the insurers in the middle of this. And so it's hard to answer the question about how it would affect insurers when, in fact, that would be cut out of the process. They would, one could, and the efficiencies that come from a single payer system are those of administration, are those of global budgets, and a form of rate setting. It's just a different model that's much more akin to Medicare in this country and to Canada and to other countries. So it's hard to answer that question under this rubric. I think I would simply say that I do think that you maybe unintentionally raised an interesting point where the mergers we're talking about here are mergers between insurers, and I think that I'm not sure that the ACA, that's a trend that's decades long and it's continuing. I think that the trend that the ACA is actually encouraging is the merging in the other direction of insurers with providers and other groups, that more integrated systems. And I think that that's a challenge for those of us who care about consumer protection and oversight, is how do we oversee those kinds of integrated systems, because at the end of the day, I think that there are both positives to that in terms of having some efficiencies and coordination of care and integration between services, and at the same time, I don't think we have a regulatory structure that is updated to be able to make sure that patients are protected when the insurer and the providers are all in the same organization.
Anthony, let me just ask you a follow-up to that. If there's only one payer, doesn't that eliminate competition? Doesn't that eliminate innovation or limit it?
Well, I think part of the question is, what is innovation? In the health insurance marketplace, the most of the innovation has been around benefit design, which I'm not sure is innovation. It has been to date mostly about, how complex and confusing can your benefit design be to, for consumers, in certain ways. I think Covered California took a huge step to remedy that by having standardized benefits in Covered California, so that, in the bronze plan or in the silver plan, the Anthem plan, the Blue Shield plan, and the Health Net plan are the same benefit design, and so you can actually have apples to apples comparisons, actually make price competition, and actually then perhaps make a distinction based on price or based on network if we have accurate provider directories, which we're working on. There's a step here, but I think, so the question is, what is the innovation you want? What is the market that you're trying to there? I think that Affordable Care Act is attempting to try to create a market that is sane. We used to have a market that was based on how effectively can insurers avoid sick people, and now we're at least attempting the novel experiment of actually trying to see if they can actually compete on cost or quality and customer service. We'll see if it works.
From an AMA perspective, probably not going to surprise you, but we believe in having a diversity of players and plans. We believe in patients having choice. We believe in physicians having choice of plans to work with. You probably know we supported the Affordable Care Act. We saw it as a unique opportunity. We didn't like every single thing in it, but a unique opportunity to expand coverage and continue to have patients have that choice. Obviously, there are a lot of things we want to work on, but to make it better. Just speaking to Medicare for a moment. So I have a lot of colleagues that we, as an organization, we work closely with the folks who work at CMS and HHS. Medicare's got a lot of good things about it. It's doing a lot of interesting work itself, but it's not perfect either, right? So they're putting out ACO plans and they're designing them from within in a lot of ways, and then they roll them out. They don't always work for physicians and patients. Dartmouth just this month. Dartmouth was one of the originators of the idea of ACOs, and they basically told Medicare, the way you design this is unworkable, and we have to pull out. The Meaningful Use program that CMS has brought forward to get all of us on electronic health records. Physicians think electronic health records have huge potential. We want to modernize, but they created a series of rules that are instead leading us to click boxes all day and look at our computers instead of looking at our patients when they're in the office. So I think looking at a single program or plan as a panacea is a challenge in some ways, and we are strong believers in making sure that all patients in this country have access to the health care they need and the right care at the right time. So we do want to expand.
We've got time for one last question, and ma'am, it belongs to you.
My name is Claire Hanlon, and I'm a doctoral candidate at the Pardee Brand Graduate School in Policy Analysis. And my question is something that Mr. Wright began to touch on in one of his last comments on the vertical integration, and to what extent, I guess I'm wondering, from a regulatory perspective, you're starting to worry about this, especially the FTC or the DOJ, because historically what we're really hearing about is insurer, practice, hospital.
I'll start. I do, again, as I mentioned, I think that that's where, if they are mergers, there are more and more relationships between insurers and certain providers. Vivity here in Southern California, Blue Shield and Dignity in Northern California. Clearly you have Kaiser. For those of you who've raised the single payer issue, I think Ezekiel Emanuel, famously the brother of Ron, who was in the White House, had an interesting theory that the way that we're actually moving is on the exchanges, is that actually, that at some level, the providers will figure out that maybe they can put themselves on the exchange. I think Sutter was actually looking at just putting itself on the exchange, and so you could have, 5 or 10 years, a situation where the exchanges are basically, your choices in the exchanges are, which provider network are you joining? You'll have a Kaiser choice, you'll have you know, at Anthem, Liberty Choice, Blue Shield's Dignity Choice, and then the local health plan, the public hospital system, choice, and that would be that, and that sort of, and then to the extent the insurer is there, it's almost more like a manager or contractor type entity, and so that's actually sort of that's one way that the system could be modeled, and that might not be, and I think, from my point of view, I think that at some level, what I want is for consumers I want this to be transparent. I want consumers to know what they're choosing and buying. That's why some of the requirements about accurate provider directories, the requirements about adequate networks and all that is just so crucial, because at the end of the day, people need to know what choices they're making. But I also want to make sure that, I think at the end of the day, patients want to make sure that the care that they are getting is not compromised by untoward financial decisions. I think that the cost issues are huge for consumers. We don't want healthcare costs there, and there is a real value in integrated care. There's a real value in having certain efficiencies, but at the same time, we want to make sure that we're getting the best possible care. It doesn't mean that we need more care. Most people don't want to take more drugs than they absolutely necessary. They don't want to spend more days in the hospital than absolutely necessary. They don't want more invasive procedures than absolutely. But they want to make sure that the care that they're being recommended is there. And I think we need to make sure that there is a regulatory system in place that gives people that peace of mind. And I'm not sure that the Affordable Care Act was very, very good about stopping the bad stuff. You cannot be denied for pre-existing conditions. You cannot be charged differently for your health status. It takes a much more proactive effort to make sure that they actually then compete on the good stuff, on cost and quality, and I'm not sure that the mergers seem to be in the opposite direction of that goal.
Okay. John?
Well, thinking about mergers between, say, hospitals and physician practices, or between physician practices and health plans, these are kind of what we call vertical arrangements. From an economic point of view, they're almost never harmful to consumers. You need a very specialized set of economic circumstances to make those harmful. But whether they're actually good or not in your industry, you've got to think about how this plays out over other sectors of the economy. We've gone through stages of automobile companies, doing all their parts in-house, and then some of them selling off the different components and spinning them off in independent companies, saying it's not efficient. So it's very dangerous, I think, for the government to specify one level of vertical integration and preferring one model over another. Because one thing we've seen in other industries is what's efficient changes over time. And what looks to be efficient in one era causes companies to spin off these vertically combined entities in other eras. So it's important, I think, that flexibility be maintained and that market forces be allowed to govern these sort of arrangements. The government's not good at that.
Okay. I want to thank you all for coming tonight. Thank you to our panel. The next forum is November 18. We don't have an exact title yet. It will involve Medicaid and whether Medicaid can handle the volume of patients that it's dealing with now. Hope to see you on November 18, and thank you for coming to UCLA.